Welcome everyone who's coming in. I'm just gonna let you trickle in for a couple seconds. You all have video powers, but not, I don't think, speaking powers. So you can wave and show who's all here. Welcome. Just gonna keep letting people in. Cool. So yeah, PHAVES number 20 is upon us. Like, wow, this is crazy.
I do have family and friends here with us.
Yay.
Hey, yeah, this is a special one because I feel like we have our regular audience of phage researchers and phage enthusiasts, and then some people from, I think, John's network, maybe newer to phage, wondering about what it's like for somebody who's actually gotten phage therapy as a patient. So it's cool to have the audiences cross over because that's not typical for us. So welcome everyone who's new and old. Okay, so the waiting room traffic has subsided, so I'm gonna get started. So I'm Jessica from Phage Directory, and we run these webinars. We've been running them a couple times a month since the beginning of the pandemic, approximately, when everybody started needing some more community time and being all alone in our houses. So that's where this was born. It was completely impromptu, but it's all about making sure we are talking to each other as a phage community and sharing perspectives and just trying to help make connections so we can keep the field moving forward. So super excited to have, and I'm going to spotlight them, Gina Suh and John Haverty here with us. They're our special guests today. And this is our doctor-patient Q&A kind of session. So we've never done this before. We had one time we had a patient talk, Pranav, from Vitalis in India, but this is the first time we've had the doctor and the patient together to kind of give their combined perspectives. And I know Gina has talked about her experience giving phages to patients a few times at phage conferences, but this is kind of, we're trying to make it more, open for people to ask what your burning questions have been. Maybe you've seen those, but you have more that you've been curious about. So feel free to, the whole time, ask your questions in the chat. And then if we get time, we'll open it up to kind of people to unmute themselves and ask if you would like. You can raise your hand using Zoom at the bottom with the, I think, reactions button. You can click raise hand. And so, yeah, so I'm going to let them kind of introduce themselves. And I think Gina's also going to present a few slides to get us kicked off. So Gina, I pass it to you.
All right. Thank you so much. And it's great to see familiar faces and unfamiliar faces. Welcome, everybody. My name is Gina Suh. I'm an infectious diseases doctor at Mayo Clinic, and I treat orthopedic infectious diseases, among other things, but prosthetic joint infections, and have more recently just kind of fallen in love with phage therapy and have been privileged to treat some patients with phage therapy, including John.
Yeah. Hi, my name is John Haverty, and I've been a long-term patient of Mayo Clinic in Rochester, but most of my healthcare was actually in La Crosse, Mayo Clinic Health System. But phage brought Gina and I together, and it's been a marvelous trip, and we have lots of stories and some good news to share.
Great. So with that, I will start sharing my screen. All right. I do have a disclosure with APT, Adaptive Phage Therapeutics. All right. So we're going to start with John's journey through his infection that has involved his right knee. I don't want to spend tons of time with this, but this is really just to convey the lengthiness of just the ordeal of it all. Right. And it started in 2008, right, with your primary.
Yes.
Yeah.
I had just had a ordinary knee replacement, and then 2 weeks after surgery, I had slipped on some ice and wrenched open the incision, which started this whole cascade of trouble for me.
Yeah, and this graphic just kind of gives you kind of a high level overview of, first it started with a staph epi infection, and then he underwent a 2-stage exchange, which is when you yank the entire prosthesis out, you give antibiotics and you put it back in. You had a terrible reaction to some of the antibiotics throughout, but one particularly bad one or early on. Then you went to develop a strep infection, for which you underwent another exchange of the metal components. And then you were on suppressive antibiotics for quite some time. Then you went on to get a third organism, Staph aureus in the knee. You got it washed out several times. You were on chronic suppression. And then now we've just covered 10 years. We are now in 2018, and you developed an Enterococcus faecalis infection, and that bug popped up 3 times in 3 different surgeries. We had you on IV antibiotics, then oral suppressive antibiotics, and just when we thought things were kind of okay, then yet another organism popped up, and that was Klebsiella pneumoniae.
Right.
And that was in 2019.
Yeah. Yep. I mean, you look at the chart and you think, oh my God, that's a lot of care. But the time involved of pre and post surgery, it burns up a good portion of the year. And over the long haul, I started developing skin allergies to chlorhexidine, to the tegaderms, to all the plastics, all of the tape that they would put on me. So it's been a ride with skin allergies, resistance to most antibiotics. So the standard of care can't necessarily be used in my case because we've blown through those options. And if it wasn't for 2019, I had 4 surgeries since Christmas 2018 and the end of February 2019, which is when I was first introduced to the word phage. And that's what changed my outlook for life and my outlook for my long-term health. Because at the end of February 2019, one of the most respected surgeons in the world came into my room and he sat on my bed. He says, John, we have 2 options. We're out of things to do. The thing to do is you can either come back every month and we'll do another washout, or the time when you get tired of that, you will tell me to take off your leg and it'll be at the hip and I won't be a candidate for a prosthesis. I'll never walk again. With 2 legs, I'll be in a wheelchair for the rest of my life. And at 62 years old, I thought that was a little bit unnerving. And thank God the world of phage opened up to me. But at the time he said those words to me, I had no idea what a phage was.
And I'd love to hear more about how it came to be that you heard about the word phage. But first I want to just tell the audience, this is John's prosthesis. And if you've never seen a total knee before in your life, just know that this one is a mega prosthesis. So it's much longer than a normal prosthesis would be. And this is the reason why his surgical options were so limited, that if you can't just take off with an amputation kind of just above the knee. You got to go higher than that because of the length, the extent of this implant. And so with that, do you want to tell us a little bit about how you heard about phages for the first time? And
yes, actually, one of the docs at the time who was at Mayo came in my room and he wrote phage on the blackboard, and I'd never heard of it. My wife's an RN; she's never heard of it. And we were saying, what are the possibilities? And he said, well, there happens to be a clinical trial at UC Davis, and we're going to submit your bacteria into that clinical study. And if
San Diego.
Was it San Diego?
Yeah.
Yeah.
UCSD.
So it would have been Stephanie's, or some, I would have met her then. But because I had more than one bacteria identified in post-surgical cultures, there was also some Enterococcus with my Klebsiella, and they wouldn't take on the 2 bacteria. So I was rejected from the study. So I went home and started preparing by looking for wheelchairs. I mean, my wife and I shopped wheelchairs, figuring this is the future. And of course, you go through an emotional time with that. A lot of depression, a lot of madness. You know, you just kind of, you have to go through the cycle of life to figure, and then come out the other side stronger. But I think we needed to have those emotions. And just when I was at the, I was ready to give up, my sister-in-law called me from Chicago. Well, she had been injured playing tennis, so she was on her couch, I was on my couch. She was in Chicago, and she would tee up all of the people she could find, on the internet that had anything to do with phage therapy in the United States. And I would make contacts, and I would send out information and phone calls. And that took about 3 weeks, and nobody answered me to the affirmative except for Adaptive Phage Therapeutics. And even Dr. Brownstein, Mike Brownstein, who was the chief medical officer, said, we're really sorry. And we would love to help you, but it's very expensive, it's time consuming, and we're getting ready for clinical trials. But, and he put the but in there, I will talk to your docs if they contact me. Well, we rapidly made the case at Mayo Clinic, and someone did call APT. And from then on, it's been a world of glory for me.
Yeah. Right around that time, just coincidentally, was when I moved to Mayo Clinic. So I was at Stanford prior, and January, so pretty much 1 month before this last surgery was when I arrived, and I had an interest in phage therapy, and heard from my colleagues, the ones who are seeing you in the orthopedics clinic, hey, we have a patient who might be a candidate. So they referred your case to me.
Mm-hmm.
There were a series of emails, contact with Mike Brownstein at APT, and with a little bit of time, we were able to start. Now, talk a little bit about what your symptoms were at the time. We're talking now March, April, May-ish 2019.
Right. At the end of February, they sent me home with the standard IV, the PICC line, 3 infusions a day, standard care. And this was after that. This was in April, early April. We were like, uh-oh, you can see the reddish part on my right leg is like, we're getting angry. And my wife's a post-surgical nurse, and she sees this stuff all the time. So she's like, oh my God. So she got a hold of Mayo and did all she could to get something hurried along. And so we were kind of pushing the panic button, and Mayo always responds. So this is the point now, just before the phages, where we're thinking that we're in big trouble and that surgery is imminent.
Yeah. And this is right around the time when, the phages were at the stage where they could be, that they were almost ready. They were biomanufactured. There are several steps, many steps, critical steps that are required to be able to, give phages safely. And we were right there. But when you and Barb contacted me, now by this time we were in touch with each other, and so we were the ones kind of making the plan for phage therapy. And mind you, I had never done this. No one at my institution had done this or even heard of it for the most part. And then there was this added sort of pressure of, it's getting red.
Right.
It's becoming angry. Are we looking at a clinical, relapse here, while after having, gone through that last washout and still on antibiotics? So we had to push this through. And what it took was a lot of reassurance and kind of pushing people. Once we had kind of FDA approval, and we'll talk a little bit about that process, we had the phages, we had FDA's blessing, and we needed kind of internal institutional support as well, or at least their blessing too, because someone had to give the phage. You had to get it somewhere in some room at the hospital. A nurse had to, draw it up. And no one had heard of this therapy. So it was a little bit of a leap in faith for a lot of the people involved. And we were asking a lot from them to say, let this patient get this therapy. You've never heard of it before, but don't worry, it'll be fine. So it was, and it's an emergency, so I need it now. But somehow, it came together. So again, APT was able to provide a Klebsiella phage. Dr. Biswas, who's called the phage whisperer, was able to discover the phage in a sewer, and was manufactured at APT, and we gave it intravenously for 40 doses. Right. So it was Monday through Friday, which is strange. When you think, why is it Monday through Friday? Well, it's because this was an outpatient infusion center that wasn't open on the weekend. And we gave it once a day because John lives an hour and a half.
Yeah, about an hour and a half.
Yeah.
Right.
So he had to drive in every day, and he had to have a new peripheral IV placed because, like he said before, he couldn't take a PICC line because of he developed all these allergic reactions to the adhesives. We decided on a dose, we decided on a duration, and slowly you started seeing improvement. Let's talk about that a little bit.
Well,
what was the process like?
It was actually fairly rapid, if we recall. I believe I had my first infusion on a Friday.
You did?
I took Saturday, Sunday, because we're not open in research. Monday, and then Tuesday was my next, I believe Tuesday was my next one.
That's right.
And I remember you walked in, Gina, and looked at it, and all she could say is, wow.
Yeah.
We saw results immediately from the very first phase that something is going on here.
And we didn't want to falsely, we didn't want to get our hopes up too much. We didn't want to believe quite yet that there was such a big and immediate sort of change. So I remember saying to each other, we could be wrong, but it really looks better. It looks less red.
Yeah, we were trying to explain it away, the lighting,
right.
The camera angle, but in reality, we saw results in a matter of days from the very first infusion of that phage therapy. And I started being a believer, and boy, I got my hopes up, and it was going well.
Yeah. How about pain? How early or late did you start to see an improvement in pain and function?
Immediately. And what wasn't predicted is that I didn't have much flex in my knee whatsoever, 15, 20 degrees max. By the end of the phage therapy, I had better than 90-degree flex, and that wasn't part of the deal. That wasn't part of the bargain. But it gave me more mobility and more life back that I didn't anticipate. And I just was over the moon with the results, and I still am.
And the bending the knee part became a really big deal because you were then able to sit in a airplane seat,
right,
in a restaurant, in your tractor.
Yeah.
And you had said to me, I remember, that you didn't want to go to restaurants anymore because your leg was always sticking out.
Yeah,
awkwardly.
I was always tripping waiters and their trays all over. But yeah, I mean, you take these things for granted if you've ever had a straight leg that wasn't bendable. I mean, you just sitting at a table like a normal person with feet on the ground is a huge achievement, and it's not overlooked as one of the greatest things in the world.
So, and so the bending of the knee part, that you also regained in the first week or so, would you say? Or
it started slowly, but if you remember, I showed up for my first infusion having to be in a wheelchair.
Yeah, you were in a wheelchair.
Because it's a long hallway down to the research department. And then once I switched over to a walker, then I was independent and on my own. I didn't need my wife to be there anymore. And by the end of the therapy, I was walking relatively well.
Yeah.
And with normal flex and normal, I mean, no one could really, I I have a little bit of a limp, but I'll take it.
Yeah, it's barely visible.
Yeah, it's okay.
Yeah.
It's okay with me, but
Yeah.
with all the damage done on my leg, I may never walk like a normal person, but I'm walking, and that's paramount to my happiness.
Yeah. And so, you know, one of us had the wherewithal to take a photo on the day of your first infusion. So that is it. It's a bad photo, but that was the day one. And you never had any adverse events, no.
There was no
Side
indication
effects.
whatsoever that anything was taking place.
Oh, Patty's on. Patty Zenz.
That's my sister, actually.
Okay. Hi, Patty. We'll get a chance to say hello to your family and friends who are on. So it should be mentioned that we never stopped John's chronic suppressive minocycline. You know, this is a drug that after all, like a decade plus of surgeries, he was on chronic suppressive minocycline, and nobody was going to stop that. And I still wouldn't stop it. It's just incomprehensible to even fathom that right now, and certainly not because we're starting an experimental therapy. So that was never stopped. But remember, all of this happened while you were on it. We just didn't want to you know, take away something that was there. So that went untouched. And there were many people involved. So Dr. Brownstein was the one that initially sort of screened your case, right? And put you in touch with or kind of facilitated. We have other key figures, Joe and Brianna and Greg, of course, and Dr. Biswas, and a few others who are not pictured here. And we also had, you know, there are folks at Mayo. Like I said, I was a new person. They'd never seen me before. I show up and I say, trust me, I got an experimental therapy I'm going to give to a patient intravenously, and I need a room ASAP. Well, it took a few people to sort of support that and advocate for us. And that was Dr. Badley and Jenny Weiss and Ellie Barbari. And then the pharmacist who's the phage landed in her lap. She's like, I don't know what this is. I have not dealt with this. Anna Bartu was willing to kind of take that step, and Mindy Shea, it was her infusion center, and she let us use that infusion center for 40 infusions. Dr. Edison Kano, who's also been, you know, essential in kind of advancing our understanding of phage therapy as well. The FDA and Cara Fiore and her colleagues were the ones who granted the emergency IND. You know, when John's leg started to look like it was acutely worsening, you know, we took the EIND route, and they were wonderful and easy to work with, and made this possible. And so this is kind of the way I see a compassionate use case, and kind of the different components that are needed. And this is not anything that is, you know, official or codified in any way. But this is how I came to, you know, organize it in my own head, is that you need three components. You need the clinical part, you know, you need the right patient, right? So you need a patient who has a serious infection, who's not responding to current clinical or current standard of care, but you also can't select somebody who's imminently going to get worse, like in an acute way, in other words, over a period of hours or days. So an acutely septic patient would not be a candidate. So things like prosthetic joint infections, where the infection is serious, limb threatening, but also there's a little bit of time for phages to be acquired and biomanufactured. The phage acquisition and delivery biomanufacturing part is also completely, essential, and APT was essential for that. And then the regulatory process was both internal and external. So we needed the help of FDA, who sets standards, quality standards, so that you're safe, right? Because none of this is of any use if we put you in danger. Right. And then your institution, you have to have institutional support. So the picture on the left was prior to phage, and the picture on the right was like 2 days into phage therapy. Yes. And so just as John was saying, pretty quick clinical results. I'm just occasionally looking at the questions coming through. Okay, so picture of the leg after therapy, and then the question is, did John have a fever?
No.
Okay, yeah, he didn't have a fever, and you all, I recall that there was maybe, did you have itching? Or like just very mild itching?
Very mild, but once we started therapy, everything pretty well cleared up.
Yeah. The next question is, are you preparing a publication? This has been published. So this was, I will have the reference up in a second, but it was published last July in CID. And the next question is, to what degree were the recurrent infections associated with biofilm formation? And did the phage screening include assaying for anti-biofilm activity? So biofilm's everything. In a prosthetic joint infection, biofilm infection is the mechanism by which these recurrences happen. So absolutely biofilm related. Was there an assay? No, there was not an assay at the time. We were just looking at planktonic planktonic activity. I, of course, didn't do that part, so I won't be able to get too much in depth about the preparation of the phage and the biomanufacturing portion, but biofilm mediated or biofilm related susceptibilities were not done. All right, so here we have some objective evidence of improvement, and our friends at Stanford were gracious enough to do some cytokine testing, and also we looked at ESR and CRP, which are very standard for looking at progression of prosthetic joint infection, and those normalized completely. Now, and then the several inflammatory cytokines also decreased over time. What does that really mean? I don't think anyone ever knows. I don't think anyone knows, but I think it's interesting. For the clinicians in the room, one thing I thought was interesting was that the CRP, which is this red line, took 8 whole weeks to normalize. And once the CRP normalized, it pretty much stayed normal. And the ESR bounced around, but the CRP was one value that normalized. And in my subsequent experience treating a few more patients with prosthetic joint infections, that normalization of the CRP seems to be almost a harbinger of how they'll do. Just an observation. I don't really know what it means yet, but that's something that I've noticed. So after the completion of 40 infusions, John was just loving life, right?
Absolutely.
And still is.
Yeah, the picture on the right is when I was invited to, actually Stephanie Strathdy invited me to be on stage with her in Minneapolis. Minnesota is my home and Minneapolis is my home. It was my first chance to get up and tell my story. And I've been a phage therapy advocate ever since, and I will do anything and go anywhere for anybody to advance the science, to give hope, inspiration, whatever it takes to get this done. I'm such a believer that it's my mission now to continue on with that.
And whose book are you holding?
That happens to be The Perfect Predator. I hadn't met Stephanie, and of course I read Mallory Smith's The Salt of My Soul, and I stand on the shoulders of those who were way ahead of me. And there are some patients that do having many more difficulties than I have. It's not, phage therapy isn't perfect for everybody every time. It's not the magic bullet, but for me, it has been. I think if it wasn't for my home run at Mayo Clinic, the first time that they ever tried it, maybe things wouldn't have advanced at Mayo Clinic so rapidly. But we're doing great work and we're taking care of lots of people. And I hear from some of them, and I'm still in conversations with two guys who've had some phage therapy, and we encourage each other, we inspire each other. So anybody that's in the research or the clinical side, or anybody that needs hope, follow our case. It's for me, it's the real deal. For me, it's a home run, and it gives me life, and it gives me a long-term outlook that I didn't necessarily have before.
Here's that day in Minneapolis with Stephanie and Barbara Haverty, John's wife. I'm gonna just switch gears just a tiny bit for the clinicians perhaps in the audience. You might wonder, why PJI, prosthetic joint infection? I've mentioned this a little bit before. We have time, so this is considered a chronic infection. Chronic should not be mistaken for not serious. Very serious, just not as acute. And I'm a PJI doc, so to me, PJI is a very important clinical indication, and I believe it is. Standard of care for treatment is highly morbid. What I mean by that is once you have a PJI, someone mentioned before, it's a biofilm related infection. So you can't really get rid of it very well with standard antibiotics unless you take the whole thing out. And that is very morbid. And for John, with that long, massive megaprosthesis that was fully integrated into the bones, nobody could take that out. So PJI has been related to all sorts of, it's been found to be, quite a morbid condition. Having a prosthetic joint infection is akin statistically, is a 5-year mortality of having, similar to having colorectal cancer. The two-stage exchange, like I was saying, is when you take the entire metal prosthesis out, you leave the patient without a joint in place. You have just a temporary joint, or even sometimes a blob of what we call polymethyl methacrylate, which is just material that kind of elutes antibiotics. And it's highly morbid for patients. There's degrees of surgical intervention that you can do, but a washout or a DARE procedure, as we call it, can be done also, but it has a much lower success rate. So a few things about John's case. So John's case is one of, I think, very, very few. I mean, at the time that we published this, there were no other prosthetic joint infection cases that were treated with phage alone without additional surgery. So that was novel. We continued the antibiotics the whole time, which is not novel. Most cases that you'll see in the literature are ones where the antibiotics are continued. So we did not have microbiologic proof of clearance at that time because we couldn't get synovial fluid, and this particular case was treated with intravenous applications of phages only, as opposed to direct application into the joint, at the time of surgery, perhaps. We just did IV, and that was new. So no surgery, only IV. Those were novel. We did a longer duration than usual, 40 doses. Don't ask me how we picked 40 doses. It was not scientific, but we wanted to compensate for the fact that he wasn't having any surgical debridement. And we wanted to err on the side of longer than shorter. And maybe you got more than you needed, but it was okay. It was a monophage preparation in that although John had a series of different bacterial infections, we targeted the one that he had last. And, if you look at this, I sometimes can't believe that this even worked, to be honest. And when we started this, we said to each other, this may not work. We'll give it a try. You may have to have another course of treatment at some time in the future, but we don't have a lot to lose. And, phages, because they're generally considered safe and non-toxic, we wanted to give it a chance. Let me just stop and see if there's other questions here. Okay. So a couple good questions. So does CRP correlate with reduction in bacterial levels? The answer is sometimes. So CRP, or C-reactive protein, is a non-specific marker of inflammation, systemic inflammation, and it is an okay marker of infection as a cause of inflammation, but not a great one. Historically, it's been used in the management, the diagnosis and management of prosthetic joint infection, and in combination with something else called Surrate or ESR. But CRP, the C-reactive protein, is a better tool than ESR and is very commonly used for that purpose. What are the criteria for choosing phage therapy for patients with implant-associated infections? So the criteria I use are, number one, do we have the bug, right? So we need the actual bacterial isolate in our hands in order, if our intention is to give targeted phage therapy where there's a match, in other words, not empiric therapy, then we must have the bacterial isolate. So that's step one. We have to have the isolate. Number two, it should be an organism for which there are lytic phages that are available out there. So Staph aureus, Pseudomonas aeruginosa, Klebsiella pneumoniae, Serratia, marcescens. These are all bacteria that have good lytic phages. E. coli, Enterococcus, examples of bacteria where there are no good lytic phages, at least to my knowledge. I don't know that there's really good streptococcal phages, for example, so group A strep, group B strep. I could be wrong, but I have not had luck in finding different labs that have phages against those organisms. So we have to have the bug, we have to have the right bug. And then the third criteria is, trying to find patients who have had a good attempt at standard of care who have not responded. in other words, if standard of care hasn't been attempted, then ethically, I think it's problematic to offer phage therapy, because you should really undergo standard of care first before you're offered an experimental therapy that has not been proven to work. And then I think, the last criteria are, patients who are willing, to undergo such a thing, having other providers who are also on board, who are supportive. If your surgeons were not supportive, then I think it would have been difficult to pursue this. I hope that answers the question. And okay, so very interesting question. Will this therapy reduce the necessity of removal of prosthesis in some cases? I think the answer to that is we hope so. So in other words, can phage therapy in some cases allow the retention of the prosthesis? I think in some cases, yes. We have one here.
Right.
So if we can replicate this result in other patients, yes, then I think there's quite a good chance of retaining the implant in some patients. It's not going to work in all patients, but it might work in a subset of patients.
And possibly reduce the need for any surgery for some cases.
Exactly, yeah. Okay. I want to acknowledge and of course the other people who are doing work in this field. Dr. Ferry in particular in Lyon in France is treating patients with phage therapy for prosthetic joint infection, and his approach is more direct administration and topical as opposed to intravenous. And he's had very good results. He has several publications now highlighting this. But the story continues. So just to recap, June of 2019 was when phage therapy started. August of 2019 was when phage therapy was completed. And then for almost 2 years, you had a nice long stretch of, tell us about your life.
Absolutely. Everything was normal and on track, and I started a new business. We have chickens, so I'm able to run around the farm with my tractor and take care of all the animals. And then in February of 2021, I had injured myself playing ping pong of all things. It was a very competitive game, but and I thought I had broken part of the components inside my leg.
The fact that you were even playing competitive ping pong is like extraordinary.
Absolutely, but I thought that was I had some pain, I had some discomfort, and so I lived with it for a couple of months. And then after my son's wedding, which I had to prepare our barn for, I took 2 weeks off. I took 2 weeks of rest, and that didn't improve the condition. So then it was time, and it prompted me to call Mayo Clinic. And so we went in for x-rays, blood work, and I thought that we would have discovered a crack in some of the hardware, and it came back absolutely perfect. Never suspecting that there was an infection in place. Never, not a clue, not a marker, nothing in my mind said we're in this for an infection, but that's exactly what came out of the aspiration. We found that we had the enterococcus present, and it was pushing some of my hardware around from its just overtaking and pushing, causing me the discomfort.
Yeah, so John, we got the call saying, hey, my knee is bothering me again. And this was in June of this year. And you can see that the right leg is more swollen. You can't see it very well here in this picture, but there's a kind of the beginning of a small eruption, a soft tissue defect in where the incision is. And, you know, we looked at this and we were like, yeah, we got to aspirate. So, and John's inflammatory markers, you know, the ones that had normalized so nicely, were abnormal, grossly abnormal. So his ESR was 70, his CRP was 59. Normal is 8 or less milligrams per liter. And the cell count was grossly abnormal. And then the culture, we were like really sort of nervous about what we would find. And it was Enterococcus faecalis. There was no evidence of the Klebsiella. If you recall, earlier in the course, there was Enterococcus faecalis was there. You know, we knew it was there.
Right.
We didn't ever give phages for it. And in fact, you know, he had been on chronic suppressive minocycline this whole time too. And we were half expecting the Enterococcus to have developed resistance to the minocycline, which can happen. But in fact, the susceptibilities indicated that the minocycline was still susceptible. So it was really it wasn't an antibiotic failure, it was a biofilm failure, right? It was the persistence of the biofilm infection.
Right.
So, you know, we were bummed, right? I mean, but John's attitude was just inspiring.
Well, the silver lining is that there was no Klebsiella detected in the aspiration that we took. So that proves that the phage given for the Klebsiella has 100% efficacy in my case.
Yeah, I mean, even if it had, you know, even if we had seen the Klebsiella, I still think that it would not have been an abject failure at all. It would have been, you know, you got some good time with a pain-free, well-functioning
Right.
knee with that first round of phages. And, you know, we had said from the beginning, if you, we may need to treat you more than once. And if that had been the case with the Klebsiella, then I think that still would have been okay. Just like with cancer cases where you have to have several rounds of chemo, you know, maybe in some cases that's what's necessary. I think in either way, it's better than getting that prosthesis removed.
Right. Oh, 100%.
Yeah.
Yeah.
But so in any case, we had the Enterococcus to deal with, and you know, we were very aggressive. We got John in, took him to the OR. We again, you know, when faced with surgical options, we were faced with, you know, removing the prosthesis, which would have left you with a flail extremity. We didn't want to do that. There's no way we're going to go there in someone who's this functional.
Right.
So we opted for a washout, you know, with his surgeons, Dr. Llewellyn, who has been wonderful, and a great partner. Took him back to the OR, washed it out, and now you are 3 weeks post-op.
Yeah, I mean, it's been a long journey. The surgery is really the easy part. Most people think that's the horrible part. That's really the easiest and the happiest time is when we get that fresh start and a chance to attack once again. And the fact that phages have been identified for the Enterococcus that I have, now pending Mayo and FDA approval, should I get that phage therapy again, this could be the very end of this medical journey. I could be free of bacteria for who knows how long, maybe the rest of my life. Maybe something comes back. It seems that once you've had as many infections as I have, anything that enters your body kind of runs home to mama and finds that weak spot in your body and attacks it once again, which is happening. What was happening just before this last surgery, a fistula was forming, and if that opened up and drained, that would have been, it's not a wonderful thing. So we caught it before it got to that point. And then, you know, the rapid response from Mayo and their wonderful standard of care, thank God, I'm in the right place at the right time with the best medical facilities. And of course, when Gina came on board, she changed the whole trajectory of my life. And I am so thankful. And hopefully this round of phage therapy will be my last. I'm counting on it.
Yeah. So APT has, found a phage for this enterococcus. We are planning to go ahead with another round of phage therapy for John. We are, we have him on antibiotics, and our hope is that with that debridement that he underwent, with phage therapy, with the continued antibiotics, that this will just keep the enterococcus at bay for just as long as possible. All right, so a couple of, let's see, questions in the chart. We have not looked for neutralizing antibodies. We should plan on that. So we want to know if your body develops an immune response to the phages. And that is something that's an important question, Joe. And we can maybe plan on doing that this round. Yeah, and that's just taking some extra vials of blood.
I read a lot of the publications on the phage page and other places that go on Facebook. I'm part of many of those groups. And I too read about the 15-day, 15 off therapies. It's not an exact science. It's still a little bit of an experimental art. But I have, there are many cases that are just home runs with this therapy. So for me and me alone, all I can do is speak on my case. This has been 100% life-giving, and other people will experience the same thing. They say 35,000 people just in the US die every year from bacterial infections. And this can save many of those people and the group of people around them, that suffer with them when they're going through these things. So I am 100% on board. I love APT. I've been there twice in person. I got to meet Carl, Merrill, and Greg, and Brianna, and Rob, and all the guys and ladies at APT, and they've stuck by me too. And so I'm so thankful and blessed to be in this position. Who could ask for more?
And it's just been nice to work with you because, as you can see, John is just a nice person to work with, and he's just been this super eloquent, articulate advocate for phage therapy. So, I also, can't ask for anything more too. So, it's been great to develop a relationship with John, with Barb, and, be able to hang out, at my house. Did you use next generation sequencing to check synovial fluid? We did not. I guess we could have, but next generation sequencing can be highly, maybe overly sensitive. We knew that John was clinically having an infection. By a conventional culture, we grew Enterococcus faecalis. Oh, I guess your question is, could we have looked for the Klebsiella by next generation sequencing? Yeah, maybe, but it didn't grow. I think the question is, if we found a bunch of organisms by next generation sequencing, which happens in normal, well-functioning knees, in synovial fluid, what does that really say? And do we chase after those things if the patient is doing well? You could argue that synovial fluid is just not a sterile space. And if you did sequencing on 100 people's knees, native knees in non-infected, clinically infected patients, you're bound to find something. So we didn't go down that rabbit hole. But you can argue also that maybe we should have. Sorry. So the process we went through to find the matching phages to the bacteria. So that's a better question for our APT partners. They're the one, I just administered the phage, right? And so they're the ones that did the heavy lifting. They they found the phage, they screened for it, they screened first, and when they didn't find it in their library, they went out and they found it. So that's a better question for them. And I don't know if we have anybody from APT on this call. Sorry, let me.
If there is, raise your hand and I'll give you unmute powers.
I guess I don't see anyone from there. Okay, so yeah, I'm sorry I can't answer that question too well. I'm a simple clinician. That's kind of it. Let's see, other questions.
I found one. What was the carrier used for the phage preparation?
The carrier used.
I saw that question come up a couple times. I'm not sure if there should be, we can get clarification.
Yeah, I am not sure.
Saline, saline, for example.
Oh, yeah. Normal saline.
Yeah.
Normal saline.
50 mils, if I recall.
Yeah. So for John, we did 50 cc's of normal saline. We infused it over what, 20 minutes, something like that?
It was something like 20, 30 minutes.
Yeah. And for the first one, we observed him for an hour or so after the first infusion to make sure there were no adverse events. And then after that, you were kind of on autopilot.
It's interesting that the pharmacy wouldn't thaw the phage out until I already had an IV established, and the nurse would then call down and they would run it up personally. And the timing has to be absolutely critical on this.
Yeah, they were sticklers for the timing. Did you observe any antagonistic interactions in the phage antibiotic combination? So I don't know. We didn't specifically look at the phage antibiotic interactions. I know that capability exists, and our friends at Baylor do this these sinograms on a regular basis, where you look specifically at any synergy or antagonism. But we didn't do this for this case. We have subsequently, but with Baylor, but not with this one.
Maybe we'll just take one or two more questions and then kind of close out for those who need to leave on the end of the hour. I don't know if there's couple more that you want to answer, Gina.
When will be the time to bring phage therapy as a part of standard of care? That's a very good question. I think it really depends on the commercialization pathway. It will require clinical trials, good, robust clinical trials, at the very least, to move along that pathway toward licensure. How long will that be? I don't know. I mean, yeah, I'm not gonna guess, because this is being recorded. Why was IV route used? Because to be honest, it's because we didn't have buy-in from, I couldn't find anyone to inject these into the knee. I mean, that's the simple question, the answer. Because, this was 2019, and there are still a lot of sort of questions and raised eyebrows when it came to phage therapy. So that was pretty accidental. Okay, so we're right at the 2:30 mark.
Yeah. Yep. And yeah, I think just thank you so much, both of you, for spending your time here with us. Like, such a cool conversation. I'm so glad with how it went. And I always share the chat with the speakers after. So, if there's other questions that you want to read and get back to people, we can make that happen. If they didn't get answered, And then we just, two things, couple announcements we always do. And then we always end, if we have time, with a little breakout room, 5-minute Zoom breakout rooms, so people can have a chance to meet a new friend or something, new face. You don't have to stay for that, but if people want to, I will divide us up for a 5-minute room at the very end right away here. And then, but yeah, just before we do that, the upcoming announcements, at least 2, but I see a couple more in the chat. Feel free to put them in. Other stuff happening in the phage world. Tomorrow is Phage Clubhouse. So we have this phage room in Clubhouse if anybody's on the audio app. I think Sabrina's here in the audience if you want to like leave a link in the chat. She runs those. So they do interviews, kind of almost like a live podcast that you can participate in. And then I see Roger has left a note about the FDA NIH workshop they're having in August, September on phage therapy. So you can register. And then the big thing we've got our minds on right now is Evergreen International Phage Meeting. So that's coming up in a couple weeks, August 1st to 6th. So you can register for that. And maybe Jan can leave the link in the chat for that. So that's my favorite phage meeting. And oh yeah, Sabrina, I see you've left a link. Awesome. So lots coming up to keep in touch, but yeah, just thank you for being here, everyone. And yeah, more questions that you missed, we can get them to Gina and John in whatever way. Just find a way to get in touch, email, Twitter, whatever works. Any last words, Gina, John?
Just thanks to everybody, especially I see my family, quite a few members are on board here today, and it matters.
Yeah. So awesome to hear.
Okay. And thank you, Jessica, for having us.
Yeah, no.
We're happy to see you. And our contact information is available. You can get a hold of me anytime.
Me too.
And I will speak to anyone by text, email, a phone call, whatever they need. If you have a patient that's reluctant or just looking for answers from another person, just like me, I'm available.
Awesome. Wonderful. Thank you. So I'm going to stop the recording.